Good afternoon, everyone, and welcome to our next Impact series. And for those of you that have signed in, I can see that many of you are entering your name and your organization. It would also be great to add your position within your organization. Again, this Impact series is really about building community. I think we'll start on slide 3 that just represents the agenda. So you can see we're going to dive into chronic disease and how we work with patients. We are also going to break out into a breakout group. And so again, this is about solution focused. Next slide. I am very excited to welcome back Dr. Ann Zink and Dr. Lisa Rabinowitz. They are going to be our facilitators for this Impact series. Please take it away.
Yeah, thanks so much, Commissioner. And it's great to have everyone here. Healthcare access does relate to healthy communities. And so I'm sure there will also be some crossover. And if you slip to the next slide, we've already started this process of putting yourself in the chat box, but would also love for you to also consider not only your role, but like where your organization is seeking advice or wants support for chronic diseases, self-management, preventative screening, really thinking about healthy communities and what that looks like for you and for you all. So feel free to put that in there. As the commissioner mentioned, this is as much of a chance to kind of create community between you all as it is for us to facilitate and try to make sure that the resources that are coming into the state are as used as wisely as possible. So moving on to the next slide, just wanted to orient you all to kind of where we're at in this process. We're here in that blue box. We welcome to the Impact series. So we're having 5 of those this week, and they are really trying to do a deeper dive into a specific topic. So we're gonna, as the commissioner mentioned, go into like breakouts and really hear from you all. We're also going to be trying to uplift some of the things that we've been hearing from the regional planning. So we've had 3 regional planning meetings so far, a whole bunch more being scheduled, because what this looks like in Utviavik versus Bethel, where one of our guest speakers is at, versus where this looks like in Seward, looks very different. And then having times for office hours and website. But really, this is to really be topic specific and dive deeper into specific topics as a whole. And if you move on to the next slide, this fits within the overall Alaskan goals for the Rural Health Transformation Project. So this is all fits within that goal 1. As mentioned, we did Healthy Beginnings this morning. These are recorded and available, not the breakout rooms, but the other parts just for awareness. And the healthcare access will be happening later, and then strengthening workforce and sparking technology and innovation. Lots of crossover, but we'll be really focusing on today's session on how do we really have impact to improve healthy communities. And if you move on to the next slide, this is what these sessions are and what they're not. So this is not a technical assistance place or a forum for approval. Thanks to the hard team working on approval. We get to dream big here. They get to do hard work there. And it's not a space for the DOH or facilitators or us. You know, Dr. Rabinowitz and I are not involved in the selection process at all to endorse or not endorse any one program. So you may have the best thing ever, but we aren't the ones to choose that. We're the ones to hear from you all and connect you all so that we can collectively find solutions together. And that's what this is for. It's this coordination along different topic lines so you can meet other people in the state or outside the state who are doing similar sorts of things or different things, challenge your assumptions, and move forward quickly together, and a mechanism to foster partnership and collaboration amongst you all, amongst the state, and amongst people interested in helping to take Alaska to an improved space of better health. Moving on to the next slide. We're going to now kind of break into the data and what we know about this space. So with that, over to you, Dr. Rabinowitz.
Perfect. So today we wanted to kind of focus on chronic disease and really empowering patients to own their health status and work on preventative care. What are some modifying factors that individuals can use to improve their health? And how do we create a health system that supports them in that journey? So this is the prevalence of self-reported chronic disease in Alaska. And you can see our rates here, and as they compare to national, want to point out asthma as being higher than the national level. And really just as we focus on chronic disease, looking at these lifestyle factors, tobacco use, maintaining healthy weight, physical activity, following a healthy diet, these are all factors that we need to think about as we march through this. And next slide. Another way to look at chronic disease is really looking at the leading causes of death in Alaska. And 8 of the 12 leading causes are chronic diseases. So cancer, heart disease, stroke, lung disease, diabetes, kidney disease, Alzheimer's are top of our list here in Alaska. So those are all things that we can improve on, and we have the opportunity to create a health system that will support our chronic disease a little bit better. Um, on here, there's a lot of things that we can't always control, but that's still built into our chronic disease. So as we look at suicide and drug overdose, those are also chronic disease issues that we can build into our system. And next slide. Really, as we look at chronic care and empowerment, we want to look at preventative care. So there's a few markers that we can use to look at that. One of those is blood sugar test in the last years, and we've only a quarter of our Alaskans have had a blood sugar test in the last 3 years. A third of women have had no mammograms in the past 2 years, and 1 in 3 adults did not meet colorectal screening recommendations, although we know in Alaska we've seen an increase in colorectal cancer, especially in our Native Alaskan populations. Routine care and ongoing care indicators, so percentage of adults who've had a personal doctor or have a healthcare provider is lagging behind national levels, in addition to those that have reported a checkup in the last year. And next slide. These are some different ways at looking at our chronic disease, and we understand that a lot goes into our chronic health and what supports that. And looking at food insecurity is a big driver of that. And we are, at 12.1% of our population report food insecurity. And there is a food environment index that we kind of follow, and that is lower than national rate. Again, this doesn't take into account subsistence food and other aspects, but it does look at where we're at economically and with the food portion of that. Housing challenges across our state, that's no surprise to any of us that are here in Alaska. It's a big issue in some places more than others, and especially in rural Alaska. But we are facing significantly higher rates than national levels, and this takes into account high housing cost, overcrowding, lack of kitchen and plumbing facilities. And next slide. Turn it over to you.
So
Great.
Commissioner, looks like she had to step off. And so I'm just going to do a quick intro for the amazing Dr. Hodges. Oh, Commissioner, there you are. Do you want to introduce Dr. Hodges?
Yes, thank you
I
so
thought you
much.
did.
I literally got interrupted with a call. I am very excited to introduce Dr. Ellen Hodges. She works with Yukon-Kuskokwim Health Corporation. She has been a great partner for many, many, many years. And Dr. Hodges, would you just share a little bit about your region, your population, and some of the work that you were doing to increase the health?
Sure. And I'm hoping everyone can hear me okay. All right. So I'm a family medicine doctor out here in Bethel. I've been out here for about 23 years, and it is an honor and a privilege to serve this region and our 56 tribes and 47 villages and about 28,000 people scattered over a pretty large geographical area. And we provide kind of a three-tiered healthcare system here. We have village health clinics that have village health aides. We have sub-regional clinics staffed by PAs and nurse practitioners, and then a hospital in Bethel that provides sort of hospital-based care and outpatient clinic services, with the Alaska Native Medical Center serving as our primary tertiary care center, kind of as the fourth area level of service that we provide. And what we know from talking to our patients here and also myself, as I age and have to get healthcare, you want to get healthcare as close to home as you possibly can. So it's so nice to hear about all these things and all these innovations to get healthcare as close to home as you possibly can. So we do have community health aides in our villages with village clinics, and trying to use and leverage technology to try to get as many specialty visits and as many visits as we can when appropriate, as close to home as possible. And I think it's always useful to think about what it's like to get healthcare in rural Alaska if you have a healthcare problem that can't be handled by your community health aid, you have to get on a small plane and you have to fly, and in some cases over an hour, and you have to go to another town, and you have to take time off of work, and you have to leave your family behind and your support system behind, and you have to get your health care in another town. And if you need tertiary care, you have to go to Anchorage or even out of state to get this care. And it's stressful and it's difficult. It's expensive. And so anything you can do to try to get things closer. So we do try to leverage telemedicine, and to do that, you need technology and you need infrastructure support for the technology to do that. And think about doing all of this with English as your second language, and the cultural translation of healthcare being difficult for yourself and for your community and your loved ones. And then, thinking about our behavioral health we mentioned that in the leading causes of death with suicide and accidents and that kind of thing. And so just thinking about leveraging behavioral health services and having someone that you trust that you could get healthcare from, as including behavioral health care, as close to home as humanly possible. I think that would be great. And then I suppose don't even get me started on tuberculosis and outbreaks and chronic diseases outside the scope of this, but imagine leveraging technology to get care as close to home as possible. So that's kind of the things that we look forward to, and look forward to talking with all of you.
Great. Thanks so much, Dr. Hodges. And TB is in there, man. Like these all get to be a part of it too. It doesn't just have to be, cardiovascular disease. It's how do we have healthy communities? So, continue to feel free to add that in. One thing I wanted to just highlight is, sometimes I'd be on these national calls and people would say, like, whenever we feel like we can't do things, I would just look to Alaska and say, well, how do you do it up there? Well, what I would do is look to Alaskans and say, how do you do it there? And so part of the reason we asked Dr. Hodges to come to this is because when you think about distance and remote monitoring and labs and the rest of it, they have a whole nother level of challenge in that space. And I see like Wendy putting in the comment, like working in Eagle River and challenge of getting labs in Willow, which is on the road system, but still a huge limitation and challenge. So going to the next slide, there's a lot of different ways that these rural health transformation dollars can be used. And there we go. So it could be, consumer facing tools. You were talking about telehealth. You were talking about, the ways that infrastructure can be helpful so that you see what happened when they went to YK, when they went down to ANTHC, or then they came back, and how does the system work together? The community health program, the community aid program, like how can we think about that in non-tribal areas and community health workers, and expanding of healthcare services, key investments for expansion for home modification. These are all things that are potential uses for this funds. But Dr. Hodges, I just wanted to kind of pause on this slide and have you reflect on, as you guys have a huge region to serve, and you're thinking about healthy communities, and the state of Alaska fairly well, where would you focus priorities for potential uses of funds if you were thinking about how to make communities healthy across the state?
So if you think about, when I think about chronic disease, I think about prevention. So taking your blood pressure medication now prevents your stroke and heart attack in the future. So an ounce of prevention is a pound of cure. I think we can all agree with that. So any way that you can support the ease of access to primary care and preventative services. Imagine tobacco cessation counseling that could be delivered right to your home at your own convenience, at the time that's convenient to you with your loved ones and your culture surrounding you. Think about how to safely deliver medications and follow-up visits that are appropriate for telemedicine. Not all visits are. We learned that in COVID, right? We learned that you can't have all the visits be telehealth, but many can. And so how can we leverage that? How can we figure out what's the safest and best way to deliver care to people that need it in as close to if possible? So you need the infrastructure, right? You have to have the Wi-Fi. You have to have the internet magic has to happen for that to work. You have to have power. You have to have reliable power. And so all this stuff has to work well for you to get this done. And then you have to work on public health education and all that kind of stuff that has to be integrated together for people to get prevention. And I think of this especially with chronic disease and those kinds of conditions that we can, you can make an intervention now, and then maybe 20 years from now, you're not having to stent someone. So it's very cool that we can do all of these fancy medical things. But if we can get into that stream ahead, up the stream, I think you can make a really big difference. And to do that, you need, the community health and wellness programs. You need to make this easy and remove as many barriers as you possibly can.
It perfectly takes us on to the next slide, and wanted to highlight a program that we've talked about before on these next ones, and that's the Fresh Start program. So that's been really Alaska as a state saying, how can we get these to prevent chronic diseases to move upstream? There's some real limitations to it as well. I mean, this is store and forward, and the information that the rural health transformation dollars can't be used for energy or internet magic, as you described it, but can use for a lot of the other things kind of around there. Also, like a payment structure to keep stuff like Fresh Start going or to expand it. So, Dr. Hodges, like, break down this program and tell us like where it's working, where it's not working, what you would do differently on top of it. There's been these efforts to do kind of preventative work like this. What do we need to do to move forward?
I think it always comes back to, talk about this in public health. It's education. It's making this easy for people to comply. Like people care about their health and they want to be healthy. I do firmly believe that. And so just removing every barrier you possibly can. I think about, this is where I get my healthcare too. I live in rural Alaska. I get my healthcare here. So like what reduces barriers for me? And it's the ease of communication with your primary care office. It's the ease of getting your medications. It's the ease of, we talk about managing diabetes. It's the ease of that. And the feedback in back to you, like, yeah, we're looking at so home blood pressure cuff monitoring is a good example of this. So you can give people their blood pressure cuff, make it as easy as possible, make the images or the values upload automatically, make it go directly to the person who needs it, who can help you with your counseling and your adjustments, and make the information culturally relevant and easy to do. That's how you're going to get people to engage in this. If it's onerous and difficult to do it, I think that also can do that. And losing weight and staying at a healthy weight, that's hard. So activity, it's hard sometimes in rural Alaska, especially, and maybe everywhere in Alaska, to be active during the winter. So how do we educate people? How do we make that easy? How do we support that and reinforce it when it occurs? That kind of stuff. And keeping people safe and helpful at home. You talk about the dementia treatment, like how can we make things available and for people to have assistance at home to take care of their loved ones, because I think healthcare is a family-centered event too, no more so than in rural Alaska with our Alaska Native population. Everyone gets involved in the healthcare of the family, and I think that's important to take that into account as well.
Awesome. Appreciate that. And I appreciate people putting in the chat box what's worked or not worked for these programs so that we can kind of think about that overall. There was a comment from Jamie about like once I used it, it wasn't available, but I wish it kind of continued to be. I know the first time I did Fresh Start, they were like, it just said, you're not eligible or you're rejected or something. And I was like, but I don't want to be rejected. I want to improve my health. Like, what does that look like? And so I think there is a lot of opportunity. And Lee is commenting in the chat box the way that leveraging smartphone technology to be able to do that and functional administration with healthcare organizations to reduce administrative burden. If you go to the next slide, this is a little bit less relevant to the Dr. Hodges part of the world because you are off the road system. So a care van, I always love it when people are like, we're going to get rural because we're going to have a van. I'm like, that's not totally there. But I would like to kind of challenge us to think about like the ways that Washington State, this is one way that they're really using their rural health transformation dollars beginning in August 2026, is focusing on providing services. And this kind of gets to the comment in the chat box earlier, like how can we get labs? How can we do testing that can go out and do hemoglobin A1C testing and screening for additional conditions? So this is another example. We just tried to provide some out-of-state examples while we also had some in-state examples. So you can also see how other people are using the funds and think about what we might want to do more in this state. Moving on to the next slide. Here is another example as well as we're kind of thinking about other things that can happen. And this gets a little bit more into kind of that educational component that Dr. Hodges did, but thinking about counseling, physical, mental health assessment for thinking about like women's health, thinking about patients with abnormal screenings or invited to attend, talking about coaching and lifestyle. So here's like a targeted population that isn't just an app telling you your blood pressure, but is a way to kind of think about how do you integrate all of this information into action that is kind of either relevant to a specific group or to a culture or a region as a whole. So how can we use like similar maybe technologies across the whole state so that we're not creating different barriers of interoperability, but that we also have things that work in Utqiagvik or Bethel or False Pass or Ketchikan, depending on what the needs are within the state. And if you go on to the last slide here for kind of this section, I just wanted to highlight the Federal Office for Rural Health Policy Information Hub. It has a ton of toolkits for thinking about evidence-based models and resources to help rural communities to implement and sustain chronic disease management. So there has been a lot of thought in here thinking about what's needed, models and examples. And so I think this is kind of an evidence-based way that people can be like, we're fitting into this and doing this, but we want to partner with people like Dr. Hodges and the YK, or we want to partner here to make sure that it is culturally relevant and that we aren't putting a square peg into a round hole, that we're making sure that we're using the expertise and knowledge from across the board to be able to fit into different spaces. Dr. Hodges, any last comments before I turn over to Dr. Rabinowitz and we work into our breakout sessions?
No, just looking forward to hearing all these ideas and stuff. It's always fun to have new and fresh ideas and an opportunity like this to just think about how can we make this better and how can we all work together. We are very interconnected as a state. I always think of that, like how interconnected we are, and how people have solved things in other areas.
Awesome. And I know that Brian is going to help us move into the different breakouts. And so maybe Brian, over to you.
Great. Thank you, Dr. Zink. Next slide, please. So in a few minutes, we are going to break out into two rooms. It will happen in the background. You will be sorted into a room. And in those rooms, we want the groups to focus on these two questions here. Across the challenges and these opportunities we discussed today, where do we think we can have the most impact? What are the top issues that we really think we need to focus on in regards to chronic disease management? And then also thinking about, where are there initiatives in Alaska or elsewhere that are working that we should explore or scale? I think we heard in our earlier Healthy Beginnings, there's a lot going on in that space that we want to learn from and scale. So this isn't just about creating things that are brand new. It's also building off of things that may be working today. So that we'll spend about 20 minutes in our groups. We'll have each group come up with a list of like top issues for where we think we can have the greatest impact and the needs. And then we'll come back and we'll do a little bit of a report out and some more facilitated discussion on how do we move these things forward. So with that, we will sort you into your rooms and we'll be back in 20 minutes.
Okay, so this morning, for those of you that were on our session this morning, I claimed that my group was definitely the best group. And I'm going to double down on that. My group was great today. So sorry, Dr. Zink.
I got some repeat customers in mind. So we got to build on this morning's conversation and keep going. So I'm continuing the theme of ours is the best.
Well, that's
despite
great.
the fact I had to check out yours first.
I just had to mess everybody up and go in the wrong room. So thanks for everyone for figuring that out.
Getting votes in the chat here, man.
Yeah. So I wanted to relay what conversations we had on our group. We kind of talked initially about integrating health for chronic care, chronic disease. How do we bring in behavioral health? How do we integrate it with education, starting in the schools, building that education in the community? We didn't talk so much about education for providers in the clinical team, but I think that's another portion of this that is worth exploring. We talked a little bit about finding the right messenger as you're going into community, as you're finding that balance, making sure that you have trust in the community, make sure it's culturally sensitive messaging. We also got into a little more specific. So we talked about brain injury as being a chronic disease, and how it's an issue in Alaska, and how do we build in those same education. Dr. Hodges talked about when she sees helmets out in the community, it's more of a rare thing that she would want. So how do we improve that? We tried to talk about cancer screening and figure out ways that we could improve cancer screening. We didn't get as far as we wanted on that, but I think there's definitely a lot of initiatives that we could use technology. Dr. Hodges had in the chat, self-collected specimens for cervical cancer screening is definitely something that has helped the initiative there. We talked about preventative upstream care. So are there ways that we can leverage, say, local gyms in communities to give part of their gym time or reduce gym memberships to help communities. And then talked about more outreach like CPR in the communities. How do we, again, build that up from the ground? So working on chronic disease from both a preventative screening and then a upstream education. So that's kind of where our group landed. I thought we had some great ideas. We had a good mix of technology expertise and local expertise. So I'll turn it over to you.
Man, yeah, it's fascinating to me how similar and how different they can sometimes be. So maybe I'll start with what was similar. A lot of good conversation on third space, like where can people gather, the importance of gathering and community, in terms of everything from like where you can, put together health and health, a screening place towards like how do you build community so people are able to connect in different ways. So there was a lot of similarities there. Big focus on food, particularly initially, and talking about how do we really make sure that people have access to healthy foods and what are some of the limitations and barriers there. There was a really thoughtful comment about like, from the North Slope about like, it's really hard to know like who's on first when we start to get into prevention. Like, is this community? Is this the individual? Is this the healthcare workforce? How do we move out from that direction and think about how do we fund this and how do we move forward? A lot of conversations on education, as you'd mentioned, like not just educating providers, but educating clergy and faith leaders and tribal leaders with health information to empower local community members to be as healthy and well as possible. Some on peer-to-peer education, a lot on like just the cost of coalition building and being in community and saying like how do we think about our community be healthy and well? How do we have prevention? I think about the ways, Dr. Hodges like builds in, like in their hospital, you can get gun safes and helmets, next to the cafeteria. I was like, way to build it in right there. And I thought Dr. Strong or Sean Scott had a really fascinating comment working both in the tribal and non-tribal system. So, Sean, I don't know if you can come off mute. If you could raise your hand, we could find you. I thought maybe you could just give your kind of one-liner of the different places you've worked and the similarities and differences you see within the tribal system as a whole. I'm just pulling a fast one on the group to see that. So he might have been pulled to something else, but I thought it was just a really great comment about. Oh yeah, we can hear you. Yeah, would you mind just sharing kind of your perspective? Because I thought it was a good kind of crossover between the tribal and non-tribal systems. That would be helpful.
Yes, so my name is Sean Vanya. I'm a family physician. I work out in Bethel under the leadership of Dr. Hodges. I've been a family physician in the state of Alaska for working on 20 years now. I spent the first decade of my career in Kodiak and then spent a couple years down in Southeast Alaska in Ketchikan on Prince of Wales Island and have been out in Bethel for 9 years now. So I have extensive experience in many of the rural areas in the state of Alaska, including tribal and non-tribal areas. And the big thing I've seen that the difference between the two is how much there's an integration of care inside the tribal organization, including diabetes, behavioral health, dental, optometry, and then multiple disease-specific entities to improve outcomes. Whereas the private communities where people do not necessarily have integrated systems have a lackluster performance, especially in the remote outlying areas, in terms of integration of behavioral health, dental, eye, and then disease-specific case management. And so, low-hanging fruit would be to develop case management for those areas that do not qualify for tribal health or federally qualified health plans.
Thanks so much for coming off and kind of sharing your perspective. I thought that it kind of crossed between this kind of tribal and non-tribal space well as we kind of think about upstream and prevention and management. So I don't know, Dr. Rabinowitz, those were our takeaways. Hand it back over to you.
No, I think that's great. And Aaliyah has just put in the chat, she's kind of compiled both of our groups and kind of things we talked about. I would love to build on this a little bit with this group just for the next few minutes. So we talked across a broad amount of things. I want to talk cancer screening for a minute and other ideas that people had for cancer screening. And Ellen, Dr. Hodges, I'm going to put you back on the spot because you touched on that in the chat a little bit about some of the stuff you're doing.
Sure. Yeah. So mammograms close to home. So we have a mammogram machine lovingly named Sophie, who can fit into a plane, but she has to be loaded in properly. She's a little fussy about her travel. And then we go to some of our sub-regional clinics. We find that people show up for those appointments like it just out of the woodwork. They just show up because it's right there. It can be done. Back in the day, we did colonoscopies in our sub-regional clinics, if you can believe that. And so we had a traveling team and it was sort of an ordeal, but we went there and our no-show rate was almost 0%. You think about being able to do your colon prep. For those of you who are old enough to have had a colonoscopy, you know that the colon prep is kind of a pain. Imagine being able to do that in your own home instead of having to go to a hotel or a hostel with a shared bathroom. So, I mean, just the chances in our polyp detection rate is really high. So sending people home with a Cologuard kit if you can't do the colonoscopy or a FIT testing, and trying to bring Cologuard processing into the state so that we don't have to mail it to, I don't know, it goes to Wisconsin or something. Just trying to get things that just reduce barriers, make it easy for people. It's inconvenient to get cancer screenings. You don't feel sick. Why would you go get care? So trying to do all that kind of stuff. Do you send people home with the self swabs for cancer? I think those have to be observed, but you can, if you can get at least get them to your village clinic to get them observed. I just think the closer to home you can get it, the better.
I think that's great. And Dr. Zink, I want to circle back to you and your group a little bit more. I think that food is medicine is an important strategy on prevention, and kind of building onto your community spaces, maybe a community hub. How could healthy foods play a part in that? Is that something that we could also do preventative screening at the same place? I think there's a lot of opportunity for that community hub. And just give me a little bit of your thoughts on food as medicine and what that could look like in rural Alaska.
Yeah, and I appreciate it. And I also appreciate Dr. Hodges. I forgot that we also talked about making technology be very patient-centered. So just like having the mammogram being in your community, making sure that the quote was used something like "make it as easy as to use as TikTok." That like it's like you've got it there rather than what is that login? What is that password? And how do I have to do it? And very patient-centric and being able to make it so not only in location, but even in the palm of your hands to move forward. I think regarding the food thing, yeah, I mean, I think there was just my sense from our group was there was a real sense of like, we need to think about how we think upstream. And that is having healthy food, getting outside and exercising, being active or having a safe place to exercise if it's really cold out, and being connected to community, where those three things were echoed across multiple people. And how do you think about it? I think there was a little bit of conversation in our group about some of the, structure challenges. So if you've got, someone on the road system who can be able to go to a church and be able to connect services there and be able to connect there versus if you've got, a community that's got very little kind of community structure, what does that look like? And the same with food. We didn't dive in a ton. I know there's been a ton of workforce on food, thinking of both as a health related social need to be able to pay for, but just like even cold storage and a lot of the SNAP payment models, et cetera, for like what food will be paid for is like a whole other scope that's a little bit outside of this. But maybe I'll punt like I always do to Dr. Hodges when I'm stuck with a hard rural problem.
Yeah.
Dr. Hodges, how would you solve it?
Yeah, so we have a prescription produce program and a food
Oh,
as
right.
medicine study. Yeah, so
Forgot about
our prescription produce program is amazing. So you send these boxes out to villages, and I think we could have a whole session just on that, honestly, and the logistics surrounding that, and the money required to get the freight out to Bethel, to get it sorted into boxes, to get it to the people who need it and want it and will use it, and food that they will use. Don't send food that people won't use or can't use and don't have the facilities to cook or prepare or don't recognize, that kind of thing. And then a native food donation program, so that if you can donate native foods, you can if you over harvest or whatever, you can share this with the community in a safe way that's hygienic, and in facilities that have the capability of processing that kind of food. And then the food is medicine, like talking to our elders and learning how to get back to treating food like a way of treating chronic diseases, and that's like really upstream, right? Like starting when people are pregnant, and really making sure that we focus on healthy foods and easy access to healthy foods, and getting the stuff. I mean, you talk about food deserts in large cities, but there's a lot of food deserts also in rural Alaska, and just really trying to focus on ways to do that. A lot of logistics in that, and a lot of smart people working really hard on that problem.
See, I knew that's why I kicked it over to you. I've even presented on that with you and totally forgot about it. So thank you, Dr. Hodges, for highlighting that and connecting people there. I know that we're running towards the top of our time and we're coming up. So I'm going to hand it back over to Commissioner Hedberg to summarize your thoughts and feelings and close us out.
Yeah, thank you so much, Dr. Zink, Dr. Hodges, Dr. Rabinowitz. Really good conversations. As a reminder, this is being recorded. This is about building community. This is about connecting many Alaskans with the awareness of what's happening, projects that are happening in the lower 48, resources that may help solve a problem. And so it was really fruitful to hear the connections and the solutions to address some of these systemic problems around chronic disease. And I am personally very interested in food as medicine, and I think that we're going to see a lot of growth in that space over the next couple of years. So on the slide, you can see our next Impact series is going to be tomorrow from 11 to 12, and it is going to be on healthcare access. And we will have another guest speaker with us tomorrow. And then we have another one on Friday, and that's going to be on workforce with another guest speaker. Next slide. So there's a QR code. Please scan the QR code. It goes directly to our website. We are continuing to update our website with information. Next week, we will be sending out notifications for those of you that submitted LOIs to provide an update on the status of the LOI. So again, please look forward not look forward, please check our website and check your inbox for information on the LOI at the end of next week. And that is it. Thank you guys for your participation in this Impact series. Take care, everyone. Bye-bye.